One of the biggest misconceptions, at least that I've heard over and over again, is that if someone is considering suicide, then there's nothing you can do, right? It's a foregone conclusion. And that's not true. We know that people who have suicidal thoughts or suicidal ideations, they can recover. They can get help. They can seek counseling, whether it's one-on-one talk therapy, group sessions. Sometimes there are pharmacological interventions through psychiatry or some combination. And so people can have a suicidal ideation or a suicidal thought in 2025, maybe not have another one for the rest of their life. So people can recover from that, which goes to how we can expand and normalize help seeking.
Hey friends, welcome to Public Health Careers. I'm Omari Richins, founder of the Public Health Millennial and host of Public Health Careers. Join us as we dive deep into public health topics and career journeys. You'll hear diverse career stories, absorb professional development and career strategies to help you learn, navigate, and transform your public health journey. On today's episode, we have Dr. Walker Tisdale III. Dr. Tisdale is a nationally recognized leader in suicide prevention and behavioral health equity. He currently serves as the Director of Outreach for Suicide Prevention Initiatives at Johns Hopkins University, where he leads campus-wide mental health strategies focused on accessibility, skill building, and community connection. With over 2 decades of public health experience, his expertise spans suicide prevention, nonprofit capacity building, mass media, policy analysis, and higher education. He holds a doctorate of social work from the University of Kentucky, is currently completing a PhD in health professions education at the University of Maryland, and also earned a master's degree from both the University of Chicago and Hunter College, and holds a bachelor's of science in broadcast journalism from Northern Michigan University. In today's episode, you'll hear and learn more about the current state of suicide prevention from our expert suicidologist, why community involvement is essential for successful suicide prevention initiatives, why education and training are crucial for effective public health practice, what he learned from working as a broadcast journalist and how he transitioned that to public health, why being patient with your career journey and aiming for higher in your career aspirations is important, and much, much more. Be sure to hit that subscribe button, that like button, and enjoy today's episode.
I'm Dr. Walker Tisdale III. I'm a suicidologist, and you're listening to Public Health Careers.
Dr. Walker Tisdale III, welcome to the show.
Thank you very much.
I'm super excited to have you on the show. As I was sharing with you before we started recording, I was very enlightened when I did a suicide prevention training with you through the QPR Institute, I believe it is. And I was like, yes, I need to get him on and share more about suicide prevention as well as your journey to getting there.
Oh, happy to do it. It's been quite a journey.
I can imagine, and we'll hear just a little bit about it. We're definitely looking forward to learning more. But before we jump into any of that, we'd love to know, how do you identify, and tell us a little about your personal background?
Absolutely. So I identify as someone with lived experience in suicide prevention. I've had family members, relatives who have made suicide attempts and those who I've lost to suicide, he, him pronouns. I'm also someone who is really passionate about public health and social services. And I identify as a gay Black man in America.
Love it, love it. And what do you like to do, or what keeps your time or interest outside of suicide, outside of public health? What's your interest?
So my interest, and I have a lot of interests. I love to go and to just find out what's new in the area that I live. I've moved around quite a bit in my career. So I'm always exploring what the city or what the state has to hold or the neighboring state. So I'm always doing weekend drives. I'm a sucker for an estate sale because I still collect vinyl. And so I have a big collection of vinyl, as a matter of fact. And I'm always interested the people who are also into vinyl because they have these huge, huge collections. As a matter of fact, just an aside, I was in Chicago, living in Chicago, and there was a woman who was going into a nursing home, and she was the previous girlfriend of Count Basie. And she had a huge record collection, huge record collection. And I came to see the property, and the family member said, well, if you buy the condo, we'll throw in the record collection. And my eyes got big as saucers. And I ended up not buying the condo. I ended up buying a house versus a condo. but I came back for the record. And when I came back, I think it was the daughter who said, well, I'm glad that you came back, but you didn't buy the condo. She ended up giving me a really good price, but that was my story because I had come. So, I mean, when I tell you literally a museum, I was just in awe. So I'm really big into music, to say the least.
Okay, well, thank you for indulging us a little bit in that as well. And before we get more into like your academic pathway to getting to where you are, I know that I shared that I connected with you through suicide prevention workshop. So, what drew you into the field of suicide prevention, and what continues to motivate you today?
So I think you actually used the right word, what drew me in, because I really was drawn in. So I started out my career in television news, which is a whole different context. But then when I changed trajectory, I moved into public health. So I got a MPH degree, and then I went and got a social work degree. And I worked in HIV prevention in the 1990s. It was the height of the HIV/AIDS epidemic, and I was working in New York City, which was the epicenter of the epidemic, if you will. And during that time, I was not only doing HIV education, but doing a lot of HIV testing and counseling. And eventually, when you do that type of work long enough, you will hear stories of people about how they got to this point of being at risk for HIV. And there were a number of people, unfortunately, who I would have to give positive test results to. And ever so often, not but ever so often, people will express not wanting to live or a suicidal thought. And I always was caught off guard. I never felt quite prepared. I felt prepared to deliver an HIV test result. I felt prepared to talk about people's risk for HIV and AIDS and how to get care, but not around the psychosocial issues around suicide. And so I, on my own, kind of pushed myself to learn more and to get more smarter about it. And luckily, at the time, I was working for the New York Department of Health and Mental Hygiene. And we had a relationship with NYU, New York University. And they had mental health workshops that were for free. And if you know me for even 10 minutes, you know I'm just a nerd for anything free and learning. So, free education. So, I would catch the bus during the day, my lunch hour, to go to NYU to sit for an hour, hour and a half workshop, and then go back to work. And I had a supervisor who supported me in that. So I say that to say, so I got really smarter about kind of the fundamentals of suicide. And then over the years, my career just took me in different areas. I worked for the federal government. I worked for the state of Georgia as the director of suicide prevention, the Alzheimer's Association. And I would say the more that I got invested in the work around suicide in different populations, the more I didn't see a lot of people who looked like me. It was a career path within mental health that just really wasn't as diversified as you would think. And so that kind of brought me to where I wanted to learn more. And in my role at the federal government and being the director of suicide for a state, I got to immerse myself. And I'm so glad that I did. So it really wasn't a trajectory that I thought I'm going to start out and I'm going to do this. I really was drawn into it.
Well, I really appreciate you sharing that, and that definitely gives us a good light into your journey, and um, helps us to kind of envision some of the more of the conversation that we'll get into as we break that down some more. And I wanted to know as well. You're talking about like realizing mental health, suicide prevention, and like the diversity part of it not being there. What does diversity in suicide prevention? What's the importance of that? Or like, well, yeah, tell us more about that.
We do not live in silos. We live in a pluralistic society. We live in a pluralistic planet. So even the countries are interconnected. But here in the United States, we're a very diversified country. And so, with that, if you're going to do anything that's public facing, whether it is public education, mental health services, whatever it is, you're going to have to get used to dealing with people of different cultures and racial backgrounds, and therefore different value systems. And suicide, which is tied to mental health, people come to thinking about suicide as an option for many different reasons. It's not just one reason, right? It's not like everyone who has a falls on hard times financially is going to think about suicide, or everyone who has a bad breakup is going to think about suicide. And some cultures deal with the idea, the concept of suicide very different. So to me, whatever you are going to do in terms of behavioral health, mental health that's public facing, you need to be prepared to deal with people who come from different backgrounds, different generations, different ages, different sexual identities, different religions. And so for me, I find it the pinnacle of really the work. It's the epicenter because I can learn a lot about suicide prevention in terms of content, but if I don't know how to deal with people and where they are from, then it's lost on me, right? You want a doctor who's going to be able to treat all types of patients around heart disease. If they're a great heart disease doctor, they shouldn't only be able to treat only Caucasian men, right? They should be able to treat everyone with heart disease.
Yeah, and that kind of speaks to the importance of having maybe some of those soft skills and being able to interact with people and understand the importance also of like representation and cultural differences in perceptions, I guess, around suicide and around mental health and around all these topics, which I feel like one of the things that I'm remembering now from the training that you did with us is that when we were doing it, I was like, this is kind of like CPR for suicide prevention, in the sense that you know a lot of folks know that you can give CPR to someone that's having a physical condition, but we don't really have anything per se for mental or suicidal conditions. And I think CPR was a great step for me in understanding like, hey, I do have a part to play. There are things that I can do in my individual life. And I think one of the key things that I learned is many times we go into a conversation and someone says, hey, I'm feeling like killing myself, and we might try to coach around the question, but we never
Mm.
ask them directly, hey, are you thinking about committing suicide, or are you thinking about actually killing yourself, to clarify that. And that was one of the biggest takeaways from the training that you shared with us.
Yeah, that's very important. I mean, I think one of the things is that people come to whatever circumstance from a different value system. And something specific to suicide, because it's such a sensitive topic and there's still a lot of stigma around it, people don't want to be offensive, right? They don't want to ask something and then the person recoil, right? Thinking about why, how dare you think that applies to me? And which I really appreciate because there's a lot of polite people out here. Right?
Mm-hmm.
And so I always say, especially in the workshops and the trainings, dare to be incorrect, right? If your gut is telling you something based on the knowledge you have, dare to ask the question directly to be incorrect and inaccurate and let the person tell you. Because there's nothing worse than even being in the presence of someone who has made a suicide disclosure, even if it's passive, and it just kind of lands like a lead balloon and nobody acknowledges, right? Because if someone were choking in a restaurant that was crowded and people didn't acknowledge the person choking, right? We would look at that scene and say, well, what happened here? What the person was clearly in distress. So we don't want people who are in emotional distress to go unnoticed.
Yeah, yeah, and I love that framing, and maybe to make it a little bit actionable for folks that are listening to this. So let's say we were having a conversation, and I was to say, uh, this job is so hard. I really don't think I want to live anymore. What how would you approach that conversation?
I would say, Amari, that's a bold statement. I hear you. Can you say more about what you mean when you say you don't want to live anymore?
Well, things with my family is hard, work feels hard. I don't know if I have the energy to continue doing this.
I hear that, brother. I would really like for us to kind of think about how we can get some support for you because what I'm hearing you saying is that your family situation is hard, the work situation is hard, you don't know how you're going to handle it, you feel a little overwhelmed, and you're saying you don't want to be here. So those things combined concern me. So I'm concerned. Would you be willing to get some help? And so
Yes.
I would literally want to ask you that. Would you be willing to get some help? Whether that's us calling a hotline together or walking to a counseling center together, but that would be my next step.
Okay. And thank you for playing along there, and definitely rewind and re-listen to it, because I feel like it's subtle, and like just the first question that you ask. But it is a clarifying question. It's like, hey, do I like? Are you really feeling suicidal? And I think, like, to your point, like when someone does disclose, whether jokingly or not, it's really important to just clarify, because you don't know if that was the one time where they felt comfortable to kind of share what is going on, and you never know what that impact will have. So I appreciate that.
Absolutely. And you have to take every disclosure of suicide seriously. Even if it seems like the person says it with a smile or they say it with a smirk, they may be joking, but it's still, you have to take it seriously.
How would you describe the current state of suicide prevention in the US, especially among underserved populations?
Omari, is this a 2 hour the state of suicide prevention in the United States is actually evolving and evolving in some very interesting and positive ways. And then in some ways, there are some areas where we definitely need improvement. So let me give you an example. So suicide prevention with under the umbrella of mental health and behavioral health in the United States is still a very young field, right? And so we don't have a pipeline, a national pipeline of people doing suicide prevention work. So just like a nurse would go to nursing school to become a nurse, right? A teacher would go to Department of Education and get a teaching degree, or a doctor would go to medical school to be a doctor. We don't have a pipeline like that specifically for suicide prevention. We have between 40 and 49,000 at the high end on any given year of people who die by suicide, a million plus who attempt suicide. So the numbers are staggering. And when you think about that over a time period, I would say over a decade, we're talking about the population of Tulsa, Oklahoma,
Mm-hmm.
right? Now, that being said, there is a ongoing endemic need because in our society, we tend to have the same amount of people who die by suicide, who make attempts and die by suicide. So we know we have a problem in the United States. We know we have a problem here. There are certainly other countries that are worse in terms of suicide death rates, and those who are better off in terms of less suicide death rates. Social workers, by discipline, are by and large the largest slice of mental health providers. So there are more social workers than there are psychologists, psychiatrists, and counselors. And so social workers, if I can pick on us for a minute, because I'm a social worker, is that we are more likely to see someone with a suicide ideation or a suicidal attempt than any other discipline, right? And yet in schools of social work, there are very little, if not no, formal suicide prevention programs in the curriculum. So most of the social workers who learn about suicide in the field learn it after graduation and they learn it on the job. So I would submit to you that's an area to where we could do better because we don't want something so important to be learned on the job. You know what I mean?
Yeah.
The other thing is that there's been a lot more research. There's a lot more focus on African American youth. There has long-standing been a focus on Native American, American Indian youth. And we know that they are overrepresented in terms of suicide deaths and attempts. So there's still some areas for us to do better in terms of population-specific risk. There's also we could do better across the lifespan because older adults, those 50 and older, 65 and older, specifically older men, are more likely to have a suicide death after an attempt because they use more lethal means. So we don't have a lot of interventions that are tailor made for older adults, and we need more diversified interventions that take into account those cultural protective factors, right? The things that really promote people from wanting to live or have hope, right? Whether you have a strong faith and you are a member of a church or a synagogue, right? Or those that enhance socialization. We know that from the COVID, going back a couple years when COVID-19 hit, we had a number of folks all over the world, if not the United States in specific, that were really kind of wrestling the 6 feet distance, right? Because that was the recommendation to stay 6 feet apart and to isolate. And when people get isolated and stay isolated, that's when a lot of the risk can really exacerbate. So I always say for suicide prevention, we need to do more in terms of develop interventions that focus on enhancing socialization, addressing the racial and cultural factors, as well as across the lifespan.
Appreciate you raising that up. And I feel like that also gives me maybe a little bit of joy to know that like there is more work out there to be done to create a more robust suicide prevention system here in the US. And all of you that are listening can play a part in that if that is something that you are interested in. So I appreciate you sharing that. What are some misconceptions people have about suicide prevention work?
I think one of the biggest misconceptions, at least that I've heard over and over again, is that if someone is considering suicide, then there's nothing you can do, right? It's a foregone conclusion. And that's not true. We know that people who have suicidal thoughts or suicidal ideations, they can recover, they can get help. They can seek counseling, whether it's one on one talk therapy, group sessions. Sometimes there are pharmacological interventions through psychiatry or some combination. And so people can have a suicidal ideation or suicidal thought in 2025, maybe not have another one for the rest of their life. So people can recover from that, which goes to how we can expand and normalize help seeking, I think is another big one, Omari, in terms of the QPR training session that you mentioned several times. I think is really a great kind of low level opportunity for anyone. You don't have to be a clinician, you don't have to be a mental health counselor, a deacon at a church. Really, you can just be someone who's observant and a caring person. But do you know the signs and warning signs of suicide? Do you know how to ask the question if you consider or you think someone is in distress? And are you willing to help them to get help? Those are really the prerequisites and what happens in a QPR session. And even if you get the training, because I think we did it in about 1 hour, 70 minutes or something, you come away with a lot of knowledge and skills. And that can really make the difference in terms of helping someone to get help and saving a life. It really can. So I would encourage everyone in the sound of my voice who's watching and hearing this to consider furthering their own education. Yeah, so that would be one of the biggest things. So that would be my plug for the QPR Institute. You're
Yeah, and
welcome.
yeah, I appreciate you sharing that. And like to the point is that it was a 1 hour training or workshop. And for me, myself, who's been working in public health or adjacent to public health 5+ years now, I was able to take some away from it. And I think to your point, it's simple enough for any everyday person to take something away from it. So even if you're taking it, like share with your family, your friends, because I think there's so much value in just creating more of a community that is, understanding and equipped with the tools and the knowledge to really address this issue head on. So I definitely appreciate that, and definitely recommend other folks to engage in those trainings as well.
Awesome.
What does public health mean to you?
Well, these are really softball questions. Public health, I mean, when you think about it, it has so many arms, if you will, and it's all inclusive. I started out my career after television in public health. I know that public health can be clean water, it can be clean air, it can be the safe spaces to exercise, right? It can be respite where you need your time to sleep and to relax. And public health can be medication, access to medication, access to care. So it can be all of these things. But when I think about public health, is really there has never been another time in my lifetime that I think public health has really been more important and how it touches our lives in so many different areas. And what I mean is that there once upon a time, as I was thinking about as I was coming of age, there was a lot of focus on the sugar in young people's foods. And then there was how much television are we watching? And then there was types of programs that we were watching, not just the amount of time, but the types of violence in the programs, and then the violence in the music and the lyrics and so forth. So public health has really been in so many different ways in our society, in our world, that it is truly without good public health, and I would even say excellent public health, you don't have a quality of life that you think that you would expect. And so when you think about your own quality of life, I'll ask you, put a price tag on that. How much would you be willing to pay for to be breathing without an oxygen tank, right? What is the value of you being able to access, healthy, fresh fruits and vegetables every day? versus only processed foods. So public health is really life-saving to me. I think about what would happen if I didn't have access to clean water. And you can look around the globe, and there are certain societies that don't have access to clean water that we may take for granted, right? There is, when I was working overseas for a number of months through the CDC, I worked in Uganda and Kenya and around an HIV prevention project. And one of the things that was brought to my attention in a conversation, it was kind of just an offhanded conversation, is that in the United States, we know that we are generally well off in compared to other developed nations. And the average person in the United States drinks about 1 can of soda a day. And this was going back to the early 2000s. And a can of soda at the time was a little over $1 for a can of soda. Now, the average person around the globe lives on less than $1 a day.
Mm-hmm.
So when you just put it in perspective in terms of kind of how we are in the rest of the planet, it is in our best interest to be invested in the rest of the planet, because it's like your neighborhood, right? What happens at the end of the block of your street ultimately could affect what happens at your house. And so what happens, several countries and time zones over could definitely affect what happens in our world. So I say that to say there's an interconnectedness about public health that I don't know if we have truly, really appreciated as a country, right? I think public health professionals know this and they get this, but I don't know as a country if we really get this.
Yeah, and it's kind of shocking that the country doesn't get it, considering like the pandemic just happened, and we've seen what one virus could do, but we don't think about that or how important it is to invest in prevention and infrastructure across the globe, knowing that viruses can easily spread in our very global world very easily. And to your point, we are all neighbors on this earth, and we are very much more affluent than much of the world in that regard, and should be doing that work to support other nations and getting some of that infrastructure. I'd agree with that.
Yeah, even when you think about in terms of mental health or in suicide, and bring it back to that, I think about as our society, and I've heard several people say this in different contexts. It seems as if people are a little more angrier now than normal. There's a
Mhm.
little more testiness in the air. And I think about whatever their cause or what we're attributing to that, those things are interconnected. We already know that, for instance, we have a proliferation of firearms in this country. Firearms are the number one use of fatalities by suicide
Mhm.
for men in this country. So access is an issue for that. We know there's been many news reports about access to medications, and there are many life-saving medications on the market that do wonderful things, but there can also be misuse and abuse,
Mhm.
and people can sometimes self prescribe or self medicate to the point to where they put their own lives in jeopardy. So there's always an opportunity for us to improve, I think, so that we can collectively have much more of a just a balance, if you will. And then when you get to the micro level, because everybody has things going on in their lives, right? Whether you are struggling financially, struggling in a relationship, struggling to keep the roof over your head, those things can exacerbate your risk for suicide, right? And so I always think about when people go to the doctor and the doctor asks you, your weight and your blood pressure and all of that, they should be asking about your housing stability. They should be asking about, when's the last time you've had fresh food? When's the last time you've been able to visit with someone? Is this your first time out of the house today? Is your neighborhood safe? Because those are the social determinants, if you will. And the social determinants of health have a really big role to play in suicide prevention in terms of protective factors.
Yeah, yeah, absolutely. And I think there is maybe like a conversation that's brewing around isolation and the impacts that that has had, and I think we don't fully understand that as yet, but it is so important to have community, have connections, friends, someone that you can count on in many, many ways. We appreciate that. So taking you back in your academic pathway, So you started off and you got a bachelor's of science in broadcast journalism at Northern Michigan University. Walk us through that thought process of going through your bachelor's program, and then maybe tell us a little bit more about your broadcast journalism um, career.
Well, it was short lived. I wanted to be before I knew that I was what school I was going to for college. I knew that I wanted to be in journalism. I was a big fan of the African American male journalists at the time. When I was growing up, there was Bryant Gumbel, there was Ed Bradley, there was a gentleman who had made it to the network years ago. I forgot his last name, but it's Mac something on ABC News. And there weren't a lot of people of color on the news, but that was what I wanted to do. And I thought that was such a cool job to be on the news. So when I finished high school, I knew that I was going to college, and I wanted to go to a school that had a really good journalism program. And Northern Michigan University, I lived in Detroit, Michigan. So if you look on a map, Marquette, Michigan, with where Northern Michigan University is about 8 hours away in state.
Mm.
So you're still in the same state, but you could drive 8 hours and then get to the school. And I had already had a full ride scholarship at Wayne State University, which was already in Detroit. So my family was like, why would you want to drive 8 hours away when you could go to school right here? And well, the other thing was that the university had a relationship with a television station.
Mm.
So a lot of the students were able to get practice on air. I knew I was never going to have that in Detroit. Detroit was a much bigger market. So here I was gung ho. I went to the university, immersed myself in the studies. I got a practicum to do I think it was WLUC TV6, and to do the weekday and evening broadcast, and then a weekend reporter position. And I think 12 people saw me on the air because it was a very small market. I mean, it was very small market, but I loved it. I loved it. I love the idea of telling stories. I love the idea of really getting to the nitty gritty and talking to people about what's important to them. I love the aspect of to me, there was a little bit of a science to it because you had to be accurate and to be correct. You just couldn't put anything on the air. And so I really enjoyed that. And the more that I did it, the better I got, honestly. But then I graduated. When I graduated, that's when the real world will tell you how good you are or are not. And so I ultimately, though I did end up coming back to Detroit, and I ended up taking a position behind the scenes as a news writer. And then I ended up getting promoted to an associate producer. And then somebody allowed me to get in front of the camera. And that was probably the best year and a half of my life because I was able to really, it was a bigger market. Like I said, Detroit was a bigger market. And I would do the overnight cut-ins. Mm-hmm. So from midnight until 7 in the morning on the hour, hi, this is Walker Tisdale, Newsbeat, right? And I think it was really about the time there was a big news story happening, and it really hit me that it was no longer just about it was an industry, right? The television business was a business. It wasn't just about telling the facts and getting the truth out there. It was about the best story, because you needed to get ratings, mm-hmm. right? What station is going to get the best ratings? And so I was a little disillusioned by that. Mm. And so at the time, I think my time interacting with so many different people as the reporter kind of encouraged me to really think about, what do I want to do next? And I knew I wanted to do something that was public facing. And it just so happened that the HIV/AIDS epidemic was happening at the time, and I had people in my life and external who were kind of really dealing with that. And I would volunteer at a community center, and so I would kind of get some firsthand experience in helping people to get to their doctor's appointments and giving them information. We would give out food boxes. So you really get to know people. And I think it was probably, honestly, over the course of a summer that I decided that public health was the direction I wanted to go in.
And how did you learn about public health as a term or as a field to want to study in?
Good question. So I remember being at this community center, and we were trying to get a grant from this place upon a hill called the CDC. And I had never really heard of the CDC in that way. And so I got very smart in terms of how do we write this grant to get this money for HIV prevention, community work. And then I learned about the public health and all the things that CDC did. And then through that, I kind of was osmosis in terms of, well, I could do this. how do you get that credential? How do you get that background? How do you get noticed? Because I had a broadcast journalism degree. So how do I get, and I always was open to learning, Amari. So it was never a barrier, an obstacle for me to kind of switch paths or to pivot. So I remember I was going to apply at the Hunter College, which I did, and I got into their public health program. And then that took me to New York, from Detroit to New York, and I think I was making a whopping $22,000 living in the studio apartment. But again, when you're young and you're just starting out, you make it work. And I was able to go from my MPH program to $22,000 working at a social service agency to I got an opportunity to interview at the New York City Department of Health. And that really opened my eyes because New York, there's talk about diversity of population. So I worked with different tuberculosis education, STD prevention. We had a public access program that I really enjoyed because it was tied to the media, tied to journalism. They had a public access program to where they would do kind of like a talk show style public health back in the day. So I would always volunteer to do that. There were special projects to where I could go to Rikers Island and do correctional health. So I got my hands dirty. And so by the time I graduated with my MPH degree, CDC came calling and recruited me, and that took me to Atlanta.
Okay, that's awesome, and I love it. Just hearing like going in wanting to be the broadcast journalist, and then as you diving into things, learning more about it, seeing that like this public health thing is something that you had interest in doing, and then pursuing that degree, and while you're pursuing the degree, I think it's figuring out more about like the public health landscape and getting intertwined in that. Um, what was that first job at the CDC? Was it that public health analyst role?
So I was and I'll say there have been so many people along the way who have really helped me or nudged me or pushed me into different opportunities. And I had my supervisor from the New York City Health Department when I told her that I was applying for the CDC position. I remember her like it was yesterday. She sat me down. She said, "Is this really what you want to do?" Because for a lot of people, New York City is the epicenter of everything.
Hmm.
And so the fact of me leaving to go to Atlanta, it was like, you really want to do that? And I remember having a long conversation, but it was some of the best support. And this was the same supervisor who allowed me to go to NYU to get those trainings. So my first job at CDC was a public health advisor in the National Center for HIV, STD prevention, TB prevention. And I think it's changed its name now. But when I first got there, my role was to really provide training and development and technical assistance for health departments. Well, that was something I had been used to because I was doing that at the New York City Health Department. But this time I was traveling around the country. So, like every month, I was on the plane like 3 or 4 times a month from California to Texas to Oregon, just going back and forth. And I loved it. I just loved it.
And you also pursued a MA in social service administration at University of Chicago. When did that come into your journey?
So that came in actually while I was assigned. So CDC, just like they give money to jurisdictions, they also can give personnel. So I was assigned by CDC for a short period of time in Atlanta. I'm sorry, in Chicago at the Chicago Health Department. And while I was in Chicago, I applied and got into the University of Chicago, their MA program. It's an AM. It's the equivalent of a Master of Social Work degree, but it's in Latin, and so don't ask me to pronounce the Latin word. But it was one of the first schools of social work
Mm.
in the United States, and so that's why it's not a traditional MSW program, but it prepares you to do clinical practice work. And so 99% of the students there are going to be therapists,
Mm.
and that was another experience that I just loved because again, I had already come from a world where I was doing HIV prevention, counseling, and testing, and dealing with psychosocial issues. So now I was diving deeper into it. And even though, like I said, it was one of the best experience academically, I still didn't get a lot of the suicide prevention content. I would get that after later, but that experience taught me about how to engage clients from different perspectives and different diversified backgrounds. How clinical therapy, how therapy, individual therapy, really is part science, but it's also a little bit of creativity because you're dealing with people who have sometimes mental health diagnoses that have manifest themselves in different ways. So I learned a lot about kind of interpersonal communication and engagement. I learned a lot about client management for that. And I think that was probably also the impetus to, honestly, for me to go to a doctorate degree down the road.
And what was that thought process for yourself after completing this MA in social services, which is essentially equivalent to MSW, to then say I'm going to pursue a doctor of social work at the University of Kentucky?
So I said, because it was a stretch in between. So I knew that I wanted to get a terminal degree at that
Hmm.
point, but I had a really great professional opportunity. And so one of the conversations I had is that, do I go to school full time or do I take this professional opportunity? Because this was at the Alzheimer's Association where I was a part of their senior leadership team in brain health. And they had a CDC funding over 5 years, which is big at the time. And one of my colleagues said, well, this is what people go to school for, is to get jobs like this. So if you have a job like this, it seems to me you wouldn't turn it down. Again, based on that conversation, I accepted this position. So I stayed in Chicago.
Hmm.
It was a pretty big role because, like I said, the Alzheimer's Association deals with dementia and brain health. This was the first time they had a federal grant like this. But I think the Alzheimer's Association has many chapters around the country. So there was another aspect of me traveling for my position. So I was based in Chicago, but I would travel. But I say that to say, but I knew that I would eventually get back to going to get a terminal degree. And it really reinforced it more because when the grant funding came to an end, and I thought, well, if I'm going to be, and I'll just share my age, if I was going to be like 40 at the time, I might as well be 40 with a degree, right? That was my thought process. And so, but it took a little while because, like I said, there were professional opportunities that kept coming my way. And I was always grateful when I think back on my career, and I'm not done yet, but when I think back on it, I have had the opportunity to work at some really nice organizations that have really shaped my career path. So when I applied and got into the University of Kentucky, it was right before the pandemic. The pandemic was just starting. And so I had just accepted a position at SAMHSA at the same time. And so we were all locked in. People were working from home remotely. So I said, well, this is a perfect opportunity because if I'm working from home, I can take this and start this degree remotely. And that's what I did.
That makes a lot of sense. I appreciate you sharing that. You were sharing in the beginning and alluding throughout your story that you were working in New York during the HIV/AIDS epidemic. What was that experience like?
So that was there is I'm looking up like literally there's a tape replaying, rewinding right now. When I got to New York from Detroit to New York, Detroit and New York are very different types of cities. Both are urban, but New York had a different feeling and hustle to it. And I had never lived in New York before. So for me, I really embraced it. I embraced it. It was rough. New York was a rough city because it was the mid Detroit is still in the Midwest, right? It's an urban city, but it's still in the Midwest. And New York, people will tell you what they think right off the bat, right? They will, it's a great training ground for public health. And so I soaked that up. And then I had some great mentors at the time. Like I said, supervisors who were supportive of me to like, yeah, if you want to go to that training, go ahead. I was starting my MPH program, like I said, in New York. I had two classes that were only offered during the day. That same supervisor allowed me to take the classes during the day. She said, just come back when you're done, boo. And so I say that in terms of I got a lot of support. I got a lot of support. So anything that I have achieved is not just Walker Tisdale that achieved it. There's a lot of people behind me and beside me who did that. But in terms of HIV/AIDS, it was also a very rough time because young people were impacted by HIV/AIDS and were getting infected. I remember doing outreach in Central Square, and you would see injection needles and equipment on the ground. Things that I really wasn't used to, but your sensitivities are really shocked, but only for a short period of time because then you still have to get into the work, right? Because people still needed the information, they needed the prevention equipment. You're talking to people about coming to a clinic to get tested or to get information or to maybe even get more concrete services like a bed at night or to get off the street. And so that's where also I think my negotiation skills kind of got honed in a little bit because as you can imagine from this exchange, I'm a talker and I learned that from New York. I really learned that from New York.
Okay, well, I appreciate you sharing that. And I could only imagine it both sounds like it was great on the professional side that they were very supportive of all the things that you wanted to do and gave you flexibility in your role. And then I could only imagine just how rough and tough the situation was with the HIV/AIDS epidemic and how much you probably just learned about public health, about yourself, about so many different things that were going on.
Absolutely. I learned boundary setting. I mean, there were so many young people that I would work with who were, they were our interns and they would come in to help us to put together. We had safer sex packets with condoms and information for young people who were on the streets. And the young people that were interns would help to distribute them. And as a staff member, we would be chaperones for the young people for their safety. And so I would see young people who just would break my heart who were in different situations
Mhm.
of vulnerability. And sometimes you hear stories about how they didn't make it or how they kind of left the city or no one has heard from them. So you kind of are left to your own devices of what happened. The same for older adults too. The homeless situation in New York at that time, this was the 1990s, early 2000s, was very dramatic. And you found that in terms of HIV/AIDS, while there was medications that were coming onto the scene more, so it was more than just AZT, people were still getting infected at high rates. And so there were a lot of people who I think there was a pivot. There came a time in prevention where there was a pivot about kind of like the Nancy Reagan, just say no,
Mhm.
abstinence. Well, that's not going to work. We need to now to kind of tailor it to where people are, right? So it became prevention, risk reduction, harm reduction. So again, a lot of my public health training really, I cut my teeth, as you would say, in New York.
Yeah, that's awesome, and I feel like I would like to like learn more about this. I was just recently reading a book, um, called "When Crack Was King," and
Mm,
and it's a people's story or retelling of the crack era in the U.S. And I think it probably has a lot of different overlaps with the HIV/AIDS epidemic, and I feel like we have a certain perception of what that was, but reading this book, it really informed me not only like Nancy Reagan, but the policies, how the over policing and like the strong on crime led to more drugs and more violence within communities and all these things, and they kind of bring it to like, we really need people with public health perspectives as mayors and in leadership decisions, because otherwise then many of these issues that are very tied to social determinants of health and other determinants of health could be impacted poorly by some of the big policy decisions that are happening.
absolutely. I remember there was a time, I think it was, I can't remember the administration. I want to say it was the Clinton administration, but I could be wrong, that actually allowed for federal funding to be used for harm reduction. And then I think there was also, if I'm not mistaken, when I was just getting to CDC, there was a lot of investments around what we would call interventions in the box. It sounds kind of like almost like a happy meal, but it is basically different interventions that were tailor made to different populations. And it was groundbreaking for at the time because people weren't really thinking about the different populations. It was a one
Mm.
size fits all approach. And so you would have interventions for LGBTQ folks, for transgender folks, for African American, for Latino. And people could really just kind of take them off the shelf, literally, and be trained in them. And then CBOs, community based organizations, could deploy them in their communities.
That's awesome. That's awesome. And I appreciate you sharing that as well. So you were sharing that while you were going into your Doctor of Social Work program, you were also starting as a public health analyst at SAMHSA. What were some of the most impactful projects you worked on during your time there?
Oh, we don't have enough time, Amari. That was probably, and I say this with all humility. You think you can only go to like, no, there's a line by Jay-Z. Now I'm quoting Jay-Z. There's a line by Jay-Z. What's higher than number one? Right. And I thought that I had, having worked at the New York City Health Department in Chicago, Health Department, the Alzheimer's Association, all these other places, that these were really great experiences. And I really did take them all with me. If you can imagine, like after I went from one position to the next, I packed up a suitcase and took all these experiences with me. So when I got to SAMHSA and I was in the process of getting my DSW when I first started at SAMHSA, like I said, it was the height of the COVID pandemic. And I had not had that experience of really dealing with COVID in that way. But one of my first assignments was to oversee a grant program for suicide prevention during the era of COVID. So specifically, we were funding emergency departments around the country who were dealing with COVID at the high volume, right? Because people were coming in distress for COVID. But how were the emergency department personnel screening for suicide at the same time? So we would provide like support for developing protocols and trainings for the personnel, many of them who are doing expert emergency medical work but hadn't done suicide prevention work. And so that was awesome responsibility, but it was also a great opportunity because we worked with states of different sizes from east to west coast, north and south, but also tribal organizations. And one of the things that I learned is that there is never a one size fits all. There's no magic bullet, not for something like that. So you really, even though that I am not there on the ground, like I'm here at the headquarters, but having the background that I had and have, and talking to people on the ground, I felt like I could parachute in, provide the support that I could, but because they're the experts that are on the ground, they are the experts. But I can say, you know what? I know this worked in California. It may work in Nevada because you have the same kind of infrastructure. Or I can say, in Georgia, they did this, but they have the same population you do. You might want to try this. So I can connect the dots a lot of times. And I think that's the value that I brought. So I love that experience because I think a lot of people got screened in the emergency departments, and we proved that you could do it when we hadn't done that before. So that's one of the things that it was like when you do something that hasn't been done before.
And that's really awesome to hear. And I think it's natural, and it's kind of crazy that we don't screen for some of these things when we have, I feel like, the opportunity. I understand probably there are like 100 million other things that are happening in the emergency room, but how can we embed public health and prevention work into the systems and the protocols that are already there? And that's awesome that you were able to do that. Look at the like systems level to also connect across to see how that peer leading and peer support could also play a part in some of that work.
Absolutely. I'm a big believer, especially now at this stage of my career, if you are doing the work on the ground, you are the expert. Just like you, Omari, are the expert in your own life, I'm the expert in my own life. You have to give deference. You may have the credentials or the letters behind your name, but that just means that you're a good critical thinker. That's me saying that. I think that academic training prepares you to be a good critical thinker in whatever the discipline that you're studying, and it's up to you to apply that in whatever the role that you're in, right? So I think in my role, like it would be silly of me to think that, okay, just because I went to school, and believe me, I am proud of my educational pursuit, but it would be silly of me to think, okay, well, now I know all there is to know about everything public health, so everybody else can go home, right? That would be. So I think, if anything, being able to know when to listen, how to apply what you can bring to the table, and how to connect the dots for people. That's really the value I think that I bring a lot. And I know that people, when I keep thinking about how I got to this point in my career, there have been people who have saw things for me that I didn't even see for myself, right? No, Walker, you really need to apply for this, right? You think so? I remember when I applied for the CDC, a colleague of mine said, "You're the type of person that CDC is looking for." And I remember saying this, almost quote, "I don't even have my MPH yet," because I was still in the MPH program. I hadn't graduated yet. And She said, so, and based on that, I applied. And it's so crazy when I think that not only I applied, can I let me tell you a quick story about the interview process. So this is in the 1990s. I was living in New York, in Harlem, New York. I had a very tight budget for everything because I was poor. And I didn't have a phone, landline phone. And so I knew that I had an interview set up with the CDC. And so what do you think that I had to do?
You had to call him from the landline.
No, I had to call them from a payphone outside.
No.
So I went down, I had to go and first of all go to the corner store and like, can I have a roll of quarters? And luckily they gave me the roll of quarters because I was not going to postpone it. I was not going to reschedule it. So I found and I stood next to the payphone so nobody else could get to it. Thank goodness the payphones were still in existence. But I stayed there so nobody else can get it before I did. And then I ended up calling them. They were supposed to call me, but I ended up calling them. And then what I did was I literally turned my body towards my back was facing the street, so I didn't get the street noise. I was trying to be a distance, have a barrier. And the interview went on for about 40, 45 minutes. And I thought I was doing pretty good at hiding that I was taking this on the street. And so the interview was done. I got a call a week later offering me the position. And the lady who would become my boss asked me, she said, we were really impressed with your answers and your responses. But we just had a question. Were you taking that call outside on a payphone? So they knew that I was taking. She said we were really impressed. We were
Mm.
really impressed, and so I think that's how I got the job too.
Mm.
So from my friends saying, "So you don't have to wait until you have the MPH." To me, like, okay, I'm just going to get a roll of quarters and say a prayer, and that's how I got to CDC.
Wow, I love that. I love that. I think both on the side, like we all need to have those friends that push us when we might doubt ourselves and our abilities to be like, no, you got this, and then also have to put ourselves in positions to take on the opportunities no matter what.
Yes.
I always think about my not as intense as you, but my what's it my job interview for my current role, my 9 to 5 role. I was in Alaska at the time, and they scheduled the interview for like 5 a.m. my time, and I was like, I'm just gonna take it, I'm not gonna tell them to change the time or anything like that, and I think they were also impressed by, by these things, but
And
yeah.
look at you now. Look at you
Right,
now.
right. Well, that's awesome. That's
which is
awesome.
which is another, I think, a hidden lesson too for us is that don't count yourself out, right? Don't self-select yourself out. We know there are people out there who are always willing to knock you down or they're willing to say, well, they're not ready, right? Somebody else is probably more deserving. I always say that now, go for everything. Go for everything.
Yeah, 100% agree with that. Let other people tell you no, or other things like that. Don't tell yourself no at the beginning. Um,
Yes.
so you also held a role, and I think this was before SAMHSA, as director of suicide prevention at Georgia Department of Behavioral Health. When you were working there, I believe you worked to build a statewide suicide prevention strategy. Tell us more about that.
So that was a position to where, like I said, there are so many experiences and you don't know what's in store. Just be open. So I was the first director of suicide prevention for the state of Georgia. And being an African American male, there were in Georgia, the field, like I said, was not as diverse as it's becoming. And so I think it was new to engage because people didn't know what to expect, right? Even though I had worked in the state before and I had worked at CDC by that time and I'd done some work internationally and other national organizations, and being the first in any role, you definitely have to prove yourself, right? There's something that's just inherent. And this position also reported some of the progress to the governor's office.
Hmm.
So that was another big thing because not only are you new into this role, but there are eyes watching, right? So do good, do good. And so Georgia has 159 counties. I think by the time I left Georgia, I've been to about 110, 111 of those counties. Um, Much of the state is very rural. suburban rural. There are some of the urban areas that we know about, like Atlanta. Um, but suicide prevention does require a diversified, robust approach. And so, in developing a strategic plan for the state, required we needed to get buy-in from as many of the counties and the county's managers and the clinicians who run the community service boards, the academic professors and researchers who research suicide prevention from Emory to the University of Georgia, Georgia State. And so I think we had a statewide work group that was just shy of 60 people. And that's a pretty wieldy group of subject matter experts. These are people who have subject matter experts. And you need their buy in because whatever strategy that you come up with, you're going to need them to endorse it, right? And you're going to need them to help to implement it in the different jurisdictions. So I was fortunate enough, again, to have some supportive teammates. We had a team of 5 that I supervised of direct reports. We had some funds from the state and some grant funds. So we were able to really have a robust strategic planning meeting that lasted a little over a year or about a year to where we had our plan. It was a 5-year suicide strategic plan, and that encompassed the entire state around different populations in the state, youth, adults, and older adults, different segments in terms of LGBTQ, Native American, African American, Caucasian. We really focused on the different interventions that were available to us. Raising awareness was a big one. So it was a multi-layered approach. And we were also very fortunate. We called upon several of our colleagues in different states who had done also some advanced work in their strategic plans. So we didn't have to reinvent the wheel. So that was a very good experience for me because one, if you can work with a very diversified group of people and accomplish something like have a product at the end, that's a major accomplishment.
Yeah, yeah, I can only imagine the amount of work that takes. I know it's challenging when I'm in like these 10 organization coalitions. I can only imagine what 660 people or 60 organizations look like. But I think that is a lot of like the public health work is, how do we bring people together to collaborate to create bigger systems and plans and frameworks to really support our areas of work within public health.
Absolutely. And once you can do that the first time, you can replicate it because now you have the blueprint, right?
Right.
And I think that's one thing that I think public health does really well, especially public health organizations, that they know that there's a value in convening people and gathering people and having meetings. No, they're not just a public health approach is not a siloed approach.
Absolutely. And you are currently in the process of getting your PhD in health professions education at University of Maryland. Walk us through the thought process of wanting to get this doctorate degree.
When you said the thought process, I think I saw your eyebrow go up a little bit.
Just maybe a little.
My family too. My family. There is when I graduated with my DSW from the University of Kentucky, I really thought that was it because I had that was a personal goal. It was a personal goal. It wasn't a career goal. It was a personal goal because I really should have continued that right after my master's of social work from University of Chicago. So I was really ready to coast. And I remember thinking I was at SAMHSA and a colleague of mine sent me an email about an information session for this HPE program and said, if you know anybody who's interested, feel free to pass it along. And of course, I'm reading it closely, looking at it. Well, this is interesting because this program is about how do we prepare the next generation of health professionals.
Mm.
I felt like my career has prepared me for that from my time at CDC, working with health departments and doing training and development, from my time in Uganda, working with volunteer counseling and testing folks to do HIV testing with couples, from my time at the Alzheimer's Association, working with the different chapters. Like I felt like there was a synergy there. So I started to look at it a little more closely and I was like, well, it's just an information session. I think it was like an hour, hour and a half. What could that hurt? So I go to the information session and it's a small group on the information, like less than 10. So I find myself, I'm asking questions. And then the one of the facilitators, the professor of the session said, you have some really good questions. Have you thought about this program? You should seriously think about it. And when she said you should seriously think about it, what I heard is you should apply. This will change your life. That's what I heard. So I did give it some thoughts, but I said I felt like it was a foregone conclusion because after I really got into it, I said, well, this is a hybrid program. I can do most of it online. It's here locally. There's a residency requirement, so I need to go in, but I could do that once a year. And I said, this would really bring everything together for my career. And I just felt I could do this would propel me to do a lot more stuff. So I applied, I got accepted. And when I tell you I got accepted, the one thing I didn't think about, Omari, now you're going to say, Walker, how could you not think about this? I was still in my first doctoral program. I hadn't graduated from that program. And this program started the last year of my social work program. So they overlapped a year. And I did not want to ask for a postponement. Like, can I postpone to start? Because I want to just do it, right? And my entire career has been, like I said, go for everything. So then I started doing a little investigation. Like, okay, my last year for this program, I have these major assignments, this capstone, I have to do this. The first year, this program has this, this, and this. And then I'm working full time at SAMHSA, right? Is this crazy? Yes, it is.
Just a bit.
Just a bit. I'm getting a second, third, fifth, and 35th opinions. Like I really did ask a lot of people because I was like, the hard part is over. I got accepted. To me, that was because getting into a PhD program is hard. Getting into 2 PhD programs is damn hard. So I said, I'm going to make it work. So I talked to my boss at SAMHSA, and I had just gotten a promotion. So I'm new in this promotion at SAMHSA. And I said, and she had written the recommendation. And I told her, and she said, you know what, Walker, if you do it, we'll make it work. Now, this kind of takes me back, Omari, because now there's a theme, right? I said when I was starting out my career in New York, I had supervisors who would allow me to take classes during the day. So first of all, ask for what you need. That's the first thing. So I did that year. Not only was I successful and I graduated from my first doctoral program, and my supervisor from my job, they all came to my online graduation. But the other thing is that my first year in this new doctoral program, I got straight A's. So I surprised myself. I should have played the lottery. There is, because whatever you do, put your mind and your focus to, it will expand. And I'm a big believer of that. So if you focus on the negative things, well, the negative will expand. But if you focus on the opportunities, well, that expands too.
I love that. And I'm glad that you were able to navigate all of that and make it through. That seems like a lot going on in one year, but seems like it was the right choice, and it worked out very well.
There's black hair that I can never get back. And now that I'm in my, like, literally, this is my last year coming up. I'm working on my dissertation. I can look back on, and I said, I've been in school since 2019. And I think about how far, and you're looking at someone, Omari, who is really, I love to learn. I am one of those lifelong learners. When I used to live in Detroit, Michigan as a child, and then we get the heavy snowstorms, I am one of the kids who was crazy enough to want to cry. I would cry if I couldn't go to school because we had a snowstorm, because that's how much I really enjoyed the learning, like in seeing the teachers. The teachers were my friends, not the kids. The teachers were my friends. And so I was always been into learning. And so even now, this is literally the last degree. So there's nothing else coming behind this. But I feel like I have when it's time for me to retire, I want to be able to say I left nothing on the table. I took advantage of all the opportunities, but hopefully I gave it back because I really do believe in mentoring young people and helping young people to get to where they need to be because people did it for me. And then to share. I always say that for young people, for young professionals, if you enter any room and there's an older adult there, try and sit next to them and listen because they have some wisdom you can't get on Amazon.
Absolutely agree with that. There's a lot of lived experience and lived wisdom that does come from just being in the work and experiencing the ebbs and flows. And yeah, there's a lot to be learned there. Walker, your current role is of Director of Outreach for Suicide Prevention Initiatives at Johns Hopkins University. What do you do in that role?
So this is also when I keep saying I'm gonna quote Jay-Z again, what's higher than number one? Because I think this is also, I keep getting opportunities, and I think the universe is now has a bigger hand to play than I did. Because when I was at SAMHSA, I would not have necessarily left that position except for there was a change in administration and their priorities. So when this opportunity came up, it really was just a smooth transition. I wish I can say that it was, highly, highly intense and competitive. It was, it was attractive to me on paper. It was attractive to me when I met the leadership there. It was part of their senior leadership team. And so it was definitely much more intense just from the perspective of focusing on a university campus.
Mm.
So I'm used to working like in cities and states, and this is a university campus situation. So that was different, but it's another opportunity to learn something different. So when I came on board and seeing what was there, it was clear that we needed to really look at what is going to be the university framework for addressing suicide prevention. Because to my knowledge, I'm not sure that they have had that framework in place. And so when I came on board, that was one of my first priorities. And so I wanted to talk to the chief mental health director and the vice provost, and to really get a sense of what could we do? Because there are some models out there for universities, college universities, in terms of addressing suicide for college students. And we know that college students are a vulnerable population, especially in Ivy League schools where the competition and the distress around competition is so intense. So that has been my priority, is kind of really working on what can we do university wide. I'm also a QPR instructor, as you know. So my goal has been also for a school this big and diverse, how can we bring more QPR instructors, not just people trained in QPR, but people who can actually deliver the training and certify more instructors. So to that, we're looking to expand that practice from our international students to regular students to faculty and staff.
What has been the biggest lesson thus far in trying to translate some of, because as you're saying, this is a university community population campus. What has been the biggest change, I guess, outside of like just that setting in doing this work?
I think, well, on the personal side, it's the commute because I commute longer. I'm getting used to that. But I think the part is the setting. The setting is probably the biggest piece. And also, it's interesting because when people come to a setting for a specific reason, right, they're not coming from mental health services. Mental health services generally comes as a result of something, right? But they're coming to get an education. The students are coming to get the best, world class education that they can from Hopkins. And so the intensity of those pursuits can sometimes bring about mental health distress, right? If they had a pre existing mental health issue before they came to the university, it can be exacerbated, right? Or it can flare up again. So I think it's how do you support students who are generally at the top of their game in their own jurisdictions, right? These are valedictorians and salutatorians, and now they're coming and their whole class is that way,
Mm-hmm.
right? So, how do you support them to achieve their life goals? Because there are some brilliant students who come through those doors, through that campus, but in a way that can also help to protect their mental health and to help them to seek help when they find themselves in distress. Because a lot of times, especially in younger people, they may not be as prone to help seeking. Like they may find if they have a cavity in their tooth, they would have no problem in saying, "Oh, my tooth hurts. I need to see a dentist." Right? But if they're having kind of an emotional distress or some anxiety or depression, there may be some hesitation to disclose that to get help. So we have to overcome that.
Yeah, yeah, that's very, very real, very real. So what does work build a comprehensive suicide prevention framework at a university look like?
So it just, I think the for any university, just like with any state, like we did this for the state of Georgia, I was talking about earlier too, because Georgia is different than Texas, which is different than Florida, which is different than New York. Johns Hopkins is different than NYU, that different than Georgia State, different than Howard, right? So it has to be tailored. It has to be customized to that university and to that campus and to their culture. It has to also include all the different stakeholders that touch students, right? So students who are spending a lot of time in labs with their academic advisors, with their TAs, in the residence halls, with faculty, you must engage those folks too, who may not think that they have a role in suicide prevention, but to kind of really help them to understand that they do have a role, right? And not as an interventionist, right? They don't have to do clinical work, but they have a role. And I think the other thing is there must be an increased awareness because oftentimes I think even when people are doing well and they're being successful, we may not be aware that there's still distress there, right? One thing to keep in mind, I think, when you consider that even the most successful people sometimes can still be sad and get depressed and anxious and still die by suicide. So, and a fat resume does not necessarily a protective factor, right? And so we must raise awareness that suicide or suicide ideation can still look like someone presenting with a smile every day, right? We have to, as they say, create a normal environment or an environment to where people can normalize seeking for help or saying, I need help. Because if people think that if I identify myself as needing help, then that's weak,
Hmm.
then they're not going to do it.
Yeah, absolutely. And I can imagine just how expansive that work is, and like as you said, like tailored and contextual to the specific university, and kind of like trying to work to shift the culture around suicide awareness, suicide prevention. And when we think to, I think a lot of the superstars or famous celebrities that we know that have died by suicide, it kind of continues to show us that, even though you have success in certain realms in life, it doesn't necessarily, as you say, it isn't necessarily a protective factor
Mm-hmm.
against suicide. And in knowing that we all have a part to play in trying to just be there for people and create avenues so that people are able to get the support and help that they need.
And that's the goal. That really is the goal. Because I think if we can raise awareness and have people to be comfortable saying, I need help and knowing where to get help, and then we can have more people trained to provide that help, I think we'll be in a much better place.
Absolutely. I could 100% agree with that. And I think this is something that we need to continue to have a conversation around as a society because we could be doing so much better. And I think it doesn't take a whole lot for us to be doing. At least maybe that's I don't know if that's the right perspective. That's the perspective I have right now. That there's so much that more that we can be doing. But I appreciate all your work, and I think it's so important that you were able to find your path in doing this work and then having impact in so many different spaces, whether that's different states around the country, and now on university campus. So definitely thank you for that work. And I wanted to move you on to the question that the past guest asked. And that question that they asked was, how do you take care of yourself and stay motivated in this work?
How do I take care of myself and stay motivated? I think for me, the motivation part comes easier because I wake up thinking about how I can use what I have been provided or given in terms of my knowledge and skills. I come from a line of mentors who have, to whom much is given, much is required, right? As simple as that. I remember there was a time, and I know this through history books, but there was a time to where people looking who looked like me, it was a crime to read. It was a
Mhm.
crime to go to school. There were segregated schools. So for me, the motivation comes very easily because I am standing on the shoulders of my ancestors. I think in terms of self care, now that's much more of a balance issue. And I just said I don't know if there is I don't know what the right work life balance is. Honestly, I don't know if it's achievable because I think for anyone who does something significant or tries to do something significant, you have to commit your whole self to it. Now there can be a relief afterwards. So at this very moment, just kind of when I was sharing going to two doctoral programs, working full time, there was no self care. Self care was sleep.
Mhm. Mhm.
Self care was sleep. So I think for me now, I'm much more aware of my limitations. So self care is boundary setting. Like I get invited to do a lot of things, and there are quite a few things I say I have to decline or just say not now. So that's probably where I am now.
Yeah, well, I appreciate the candor in your response, and I hope that you are able to find whatever that balance is. And I always think about like life as in like work life balance. I don't know if that's a thing, but knowing that like there's seasons of different priorities and figuring out how to work within those seasons of life, I think is how I'm trying to view it at this moment in time.
I like that. I like that.
Awesome. And then moving you on to the Furious Five, the five questions that I ask all guests.
Okay.
So, number one, what advice would you give to a student trying to pursue a career in public health?
To pursue a career in public health, I would just say make sure that it is certainly something that you are not just professionally aligned to, but that it aligns with your personal mission, your personal motivation. Because public health is hard work.
Agreed. Number two, if you were talking to someone wanting to get into your position, what advice would you give them?
Aim higher.
You know, add anything? You know, add anything? You know, add any context to that, or is that all?
I say that when I say to aim higher, I mean literally aim higher than where I am because I think don't limit yourself to a position. Don't limit yourself to a position. Maybe after a certain amount of experience and expertise, you may be the person that, you know what, I have an idea for me to start my own nonprofit or to start my own organization. Maybe that's what the world needs. I mean, because I think there is opportunities to always work for another employer. I honestly do. I think the world will always need a knowledgeable, skilled workforce, and so aim higher.
Number three, what's something you're working on improving in your life right now?
That work life balance.
That's fair. That's a common response for that question. Number four, professionally, do you recommend anything? A book, podcast, YouTube, online resource?
There are several things I could recommend. One, I would definitely recommend what I was saying earlier in terms of if you find yourself in the room with an older adult, specifically an older adult who has achieved something significant, try to make yourself known to them. I cannot tell you the conversations that I've had with some amazing folks who have done some amazing things in this world that have helped me. It's the reason why I don't need therapy today. Take advantage of that. I think another is that a book that was given to me as a gift, college gift, and a gift in college for the holidays, and I have found myself giving it out over the years. Miguel Ruiz, The Four Agreements. It is one of those books that is just simple. It's not a heavy read at all, but it helps to center what is your purpose and how you walk through the world. And then I think the one thing I would say, and I said this earlier, go for everything. Don't hold yourself back. Don't limit yourself. Don't self select yourself out. If you don't know, there's one job over here, there's one job over here, I'm qualified for both and I'm interested in both, apply for both. No, if there's no an opportunity that you think that you could really thrive in and contribute to, go for it. So go for everything.
And then last but not least, if there was one piece of advice that you'd give to your younger self, what would that be?
I think one piece of advice I probably would give to myself is that even though the opportunities would come in different ways than I have thought, right? I would say to myself to be patient, to be patient. Because there was a time, and I say that because there was a time that thought, well, if I don't do this, this is not going to come around again,
Hmm.
right? And which it seems counterintuitive to what I just said about go for everything. But I may be looking for an example, I was looking for to have a supervisor, a leadership experience. And it didn't come in the time that I thought it would come in the time frame, but it would come later and it would come in a much different form and in a much significant role. So just because you have a plan, don't think that the universe or God or whoever, they may have a bigger plan that could be a little better or different than yours. So be flexible, I think, in your career planning. That's probably the take home. Be flexible in your career planning.
Dr. Walker Tisdale III, greatly appreciate this conversation. It was amazing to be able to do the QPR training with you, and now I'm so glad that we're able to connect and hear more about your journey and hear more about the insights that you have gained throughout your journey.
Thank you so much for the opportunity, Omari, and thank you for elevating this to the public health community about the different career paths. So thank you.
It truly is my pleasure. Housekeeping items, everyone. Thank you all so much for watching or listening to this. Be sure to subscribe, to leave a like, to leave a review, and share it with a friend. Greatly appreciate you all. Peace, everyone.